So I was asked to talk about ventral cervical fixation, and to give credit where credit is due, I just stole one of Greg's presentations and modified it a bit. So we're going to talk a little bit about sort of what we would want in a cervical fixation system, look at what's available, and then we'll also talk about how some of the techniques we can use in the anterior instrumentation and what we can accomplish with it. So if you think about what would you want in the ideal cervical instrumentation, well, you want something that's going to be immediately stable. You want to improve fusion rate. You want to be able to correct deformity. You want low profile to prevent swallowing difficulties. Should be easy to use, minimal risk of hardware failure. It would be nice to be radiolucent and certainly non-magnetic, and that it complies with Wolff's law, that bone forms in response to strains, so you want to be able to put strains on your implants. So what are the plates supposed to do when we think about it? And you'll notice I went straight to plates because really here, anterior or ventral cervical fixation pretty much is now all plate constructs. I will show one rod-based construct during the course of this. But basically, we need to keep the graft in place. It needs to provide rigidity. It functions as a tension band ventrally in extension. It should be load sharing. Though occasionally load bearing has its own issues. We want it to improve fusion rate, and most clinical studies do show that it does improve fusion rate. And of course, we want to improve clinical outcomes. We don't want to add cost to a procedure if it doesn't add value or doesn't improve the clinical outcomes. But by and large, the basis, what we're trying to do is optimize the fusion environment. So you can do an uninstrumented fusion with reasonable success, particularly at 1 levels. As you increase the number of levels, the pseudarthrosis rate goes up. So you may want to preserve, or you may want to use instrumentation more. We can argue, and there are arguments that plates preserve lordosis better than an ungrafted fusion. And if you believe that adjacent segment degeneration is as a result of loss of alignment, that may be an argument that you want to make. So just a little bit of biomechanics. The concept of triangulation, as mentioned earlier, in converging the screws in the axial plane, diverging the screws in the sagittal plane, improves your your pull-out power. The concepts of load bearing, load sharing, and cantilever beams. So this is the idea of triangulation. If you look at the resistance to pull out, so if you have a force acting to pull this plate away from the spine, the more bone that you capture in these triangles, the more resistance to pull out you're going to have. And that is why all the current generation of plates have some degree of the ability to angulate. Now, where you get in trouble with this is some of the semi-constrained plates that allow multi-axial screws. You may not actually be getting that triangulation. So if you're using an angular semi-constrained plate, really think about making sure you're converging your screws to preserve this concept of triangulation to prevent pullout. This is a cantilever, a fixed moment arm cantilever beam. This is biomechanical concept. The plate is fixed here, load, a force is applied here. The maximum area of strain is here. Ed always liked this picture. This is the concept of load bearing versus load sharing. So if we remove the vertebra in the anterior column and we don't replace it, all of the load is going through the hardware, puts a lot of strain, a lot of load on the hardware, and we will get failure at the point of maximum stress here. By restoring the anterior column, our implant is now load sharing. So it is bearing some of the load, and so that stresses the importance of good carpentry. If you put a fixed angled plate on, one that does not allow any subsidence or does not allow any angulation, and you leave a gap in the bone, you're going to end up load bearing. Poor carpentry is part of what leads to failures of implants, pseudarthrosis. So now we're going to start looking at the types of plates we have available to us. And most of them now fall into one of these categories or combinations thereof. There are plates that are restricted back out. They prevent the screws from coming back if they loosen. We have constrained, where the screw is locked to the plate, creating a fixed moment arm cantilever beam. It does not allow any rotation or sagittal alignment change. And does not allow any subsidence. And then there are the semi-constrained plates, the rotational, the ones that allow the screws to rotate in the plate, and the translational, the ones that allow controlled subsidence. So this is the sort of one of the very first plates, the Caspar-Orozco plates. A screw would go in, and there was nothing to prevent the screw from backing out. This plate was designed that the holes would and the slots, so it would allow some settling or translation. Generally, not a plate that's typically used much anymore. This was sort of the next plate to come along, the Synthase CSLP, cervical self-locking plate. It had an expandable head with a set screw that went in it, and this created a locked device. So a fixed moment arm cantilever beam or a fully constrained plate. This would be something you might want to consider, for instance, if you like to use an anterior reduction and fusion for your bilateral jump facets. By having a fixed cantilever beam, you lessen the chance of recurrent subluxation or dislocation. This is another, I can't remember which one this is. This was the Orion plate.
It's the Orion plate.
Yeah, the Orion plate from Medtronic. Then we had some of the semi-constrained plates. So this is a plate that allows, there's a lock nut here that prevents backout. And this plate allows some angulation. And then there are hybrids where you can have fixed at one end and pivoting at another. This is what I tend to like to use in my ACDs. So I will use the shortest plate I can because of Dan Rue's study that showed the more proximal and more distal you get, you increase adjacent segment strains. So I like to put a fixed in the bottom to give a little more rigidity, and then an angled so that I can angle my screws up from the anterior corner. Translational plates. One of the examples here is the Premier plate. This is not the Premier plate. This is a plate from eSkillApp, but essentially there's a slot here. And so what happens is that if you get any settling, any reabsorption of your bone graft, it translates, and you can see across this two-level construct, when it's first put in, the upper set of screws are right against the end of the plate. In theory, because of the contouring of the plate, you may get subsidence and preserve lordosis with these plates. This is the older system. This is the Dock plate from DePuy. And again, the idea here was that you allowed a little bit of controlled subsidence. Screws here, this would rest on the edge of the vertebra, and you can see how there would be motion there. But you don't want it to subside too far to increase failure. And this is yet another example of it. You can see, and if you look at this plate, each successive slot is slightly longer. This is kind of interesting. Here, the use of a translational plate, but then backing it up posteriorly. If you've got a rigid posterior fixation, you're not likely to get much translation anteriorly.
But so the reason that this is included is that it actually shows that it does subside some.
Thank you, Greg. So looking at the implant application, one of the first things, the concept of gardening the spine, we know that the higher profile your plate is, the more likely you are to have dysphagia. So you want to, by gardening the spine, you want to remove the anterior osteophytes so that you have the lowest profile plate possible. One of the other things that I like to do is I will put my inferior screws in first, but I won't sink them all the way down in a restricted backout device. I will then put my superior screws in, and I will sink those down. Because the worry what you can get into is if you put your inferior screws, your caudal screws in first, you put them all the way down and lock it, you can pivot your plate up, and so you'll have the plate impinging on the posterior oropharynx or the esophagus. So by putting it in part way, putting it down and then bringing it down, you're going to maintain the lowest contour possible. In terms of which implant to use, there isn't a lot of evidence that any one is any better than any other. I think if you're doing a multi-level construct, there are some advantages to a translational plate because that little bit of controlled subsidence does allow Wolff's law to act. One of the big things looking at getting intermediate points of fixation, Unilateral versus unicortical versus bicortical screws. In the early plates that had that were completely or essentially unconstrained, the biomechanical studies showed that bicortical purchase provided better rigidity. I think with some of the more fixed restricted plates, that is less of an issue. But again, in really poor bone quality, you may want to get bicortical purchase. It is a little bit stronger. And then we'll look at bone grafting options and the idea of putting a screw in the bone graft as we go on. So one of the kind of things we knew early on in plates, if we used multi-level plates, there were problems with the plates either cutting out inferiorly, or what would happen is they would loosen because the plate can toggle. And because of that, there was a very high failure rate with these. And for a while, there was the concept of you would just put an anti-kick-out plate down here. But part of that is that this plate, because it allows translation and rotation a little more, it's not as rigid. So if you can convert this into a 3 or 4 point bending construct, you get much more rigidity. So if you are doing a multi-level corpectomy and you don't want to go posteriorly, you may want to consider the possibility of putting intervening segments, either by doing multiple discectomies if there's no compression behind the vertebral body, or another option is to do a hybrid construct where you'll have a corpectomy plus a discectomy, and that gives the intervening points of fixation, which give you more rigidity. So again, this is just the idea here. Another advantage of an intervening point of fixation is that by over-contouring the plate, you can restore some lordosis by bringing the spine up to the plate. One of the arguments people get into is by leaving things behind, you may not be able to get as good a decompression. But one of these strategies you can use to do that is by leaving an intervening vertebral body, you can do the so-called Erlenmeyer flask decompression. So what you can do is you can work this way and remove this posterior osteophyte by coming across here, and you can still decompress this area and leave an intervening point of fixation. So in my hands, what I do is I look at my MRI. If there is any place where there is CSF behind the vertebral body, I will leave that vertebral body in. If there's not CSF behind the vertebral body, I will try and take I will tend to remove that vertebral body. So I would rarely do a multi-level corpectomy without an intervening point of fixation. If I do, for whatever reason, find I need to do a 2-level corpectomy or more, I will tend to back those up posteriorly because of the rate of failure. I think getting the intervening point of fixation in will often prevent you from needing to go posteriorly. So we can also use our instrumentation to help in deformity correction. We're learning more and more that just like the lumbar spine, restoration of lordosis is really, really important in outcome in patients. And Greg is going to talk a little bit more about that in a biomechanics talk coming up, I think, tomorrow. Yeah. So a couple of options that we can use to restore lordosis. One is we can use our distractor pins. So when I put my distractor pins in when I'm doing a discectomy, I always try and slightly converge them. And that way, when you put your distractor down and distract, you will restore some lordosis that way. And in a multi-level construct, I spend a lot of time doing that, making sure that I'm getting a little bit of lordosis at each level. Another strategy you can do is the concept of bringing the spine to the plate. So you put your plate on, you affix it, cephalad and caudad, and you over contour it, and then place. And what I tend to do when I do this is I place both screws, and then at the same time tighten both screws down, and that brings the spine to the rod. I don't like to do it with one screw at a time because the risk of pullout. And so if you're doing it with both screws at the same time, I do one, my resident or fellow does the other. We both work at the same time and bring the spine to the rod. And here's just an example showing this with the dock plate system on a sawbone. So you can see we've over contoured the rod. The screws are going into the intervening vertebral body and bringing the spine up to the rod to restore relatively nice lordosis. So looking at how we reconstruct the graft, one of the graft selection, the keys to graft selection, the things you need as big a footprint as you can because it bears the most load, and you want a good biological a good biological fixation, or potential for biology. One of the problems I have with some of the PEEK implants is some of the PEEK implants are fairly large, and I'm not sure in some of the PEEK implants we're getting enough bone growing through the cage. Just personal editorializing there. So when we look at what do we have available to us, well, the gold standard in terms of getting something to heal is still autograft. Either iliac crest, or if you need a longer construct, autograft fibula. I haven't done an autograft fibula in a long time, actually since residency, but it is something you can use. And then we also have the allograft, same iliac crest fibula. I don't know what the status here in Pakistan is of the availability of allograft. My understanding is it's not very good. Certainly that's something to consider. And the bottom line is patient's own bone is cheap. You're not paying for an implant, and that's it's the best lowest cost implant. So there's a fair bit of value there, though there are the problems with the donor defects and the pain from that. We also have various interbody struts. We have our implants, titanium mesh, PEEK implants, telescoping cages, or the expandable cages. And then there's also, just like the threaded intervertebral body cages we used to use in the lumbar spine, there are threaded intervertebral body cages for the cervical spine, though they're not commonly used much anymore. There wasn't enough bone graft surface there, and they tended to have some failures. So in conclusion, the main ventral cervical fixation now really is plates. There are multiple options, and each have their advantages. There's no one that is specifically better. And without a doubt, there is no substitute for good carpentry. If you don't get good end plate preparation and good interface between your graft or your cage, whatever, you are going to get failures. So the plates are not a substitute for good carpentry. Thank you.